Hello, good evening. My name is David Quati. I work as a country head for Allegan AbbVie. So, Allegan, as you know, is a manufacturer of some of glaucoma products in the markets. You can talk of Alphagan, you can talk of Combigan, you can talk of Ganforts, Lumigan. And then there also we have dry eye disease products like Refresh Tears and Refresh Liquid Gel. And I think this discussion go a long way to have a wide knowledge of Refresh range. And then also we have other products in the allergy fraternity, which is Relistat. We also have steroids like Pre-40. We have a mild steroid in combination with antibiotic as FMNU. We also have antibiotic Ezocin, which is available also in the market. So Allergan currently is bought by AbbVie. AbbVie itself is from a mother company called Abbott. I know most of you know about Abbott. So Abbott splitted into four companies 3, 4 years ago. So we have Abbott Nutrition, we have Abbott Diagnostics, we have Abbott Instruments, and then all the specialized products went to AbbVie. So the ABB is Abbott, and then the VEI, which is VIA, is Life. So it's Abbott Life. That is where we got the name AbbVie. So currently, AbbVie has bought Allergan. So with few months or years to come, we'll not hear of Allergan again, but all our packages will change to AbbVie. Then today, what we wanted to talk about, we have a resource person in the name of Dr. Ruba Bacha. Dr. Ruba Bacha is the medical liaison of AbbVie Allergan. I think with that much I'll leave the floor for Dr. Ruba to take over the program. And then lastly, I wanted to remind you that there is a chat box on your screen that you can send your suggestions, your questions, and then your comments. We thank you very much, and please, all the best. Enjoy the presentation.
Thank you, David. Thank you. Good evening, everyone. Thank you for this opportunity to be presenting today to your respectful audience. My name is Ruba El Basha. I am a pharmacist and I'm undergoing studies in public health with London School of Hygiene and Tropical Medicine. I am based between Lagos and Nigeria, and I'm in charge of medical affairs of PHA. PHA, the official representative of AbbVie Allergan in region Africa, including Ghana. Today, we will be discussing the first part of dry eye disease modules. And I'll start by sharing my screen with you. Please confirm that you can see my screen. So The whole program, educational program, is called Ocean, and it is about management of dry eye disease in clinical practice. So, what is Ocean? The Ocean Medical Education Program is a practical educational resource that is addressed basically for general ophthalmologists, but that can be also addressed to other healthcare professionals who can be involved in the management of dry eye disease, such as community pharmacists. The program is educational. It addresses the numerous clinical challenges of managing dry eye disease, and practical aspects are also covered in the following modules, including diagnostic tests that identify different classes of dry eye disease, and how targeting specific areas of concern can improve the clinical care of patients with dry eye disease. The program highlights the four key stages of the vicious circle of dry eye disease pathology, because you're going to see later on that dry eye disease consists in four stages that are interconnected to each others. And the program demonstrates how appropriate diagnosis and treatment can improve patient outcome. These are the Ocean panel of experts in dry eye disease. The Ocean is Osmoprotection in Dry Eye Disease Expert Opinion Panel, and it comprised several members from different countries, from Turkey, from France, Italy, Greece, Spain, Germany, and the UK. So these experts, they are behind the development of these modules, and they come from different countries. So they bring their country-specific, let's say, practices into that educational program that we're going to discuss today. The panel first met on 14 December 2012 to discuss the role of hyperosmolarity in the pathogenesis and management of dry eye disease. And the term hyperosmolarity, you will become familiar with it and with its implications on dryness of the eyes later in this presentation. So today we will be talking about the challenges in management of dry eye disease, the ocular surface structure, the prevalence, the risk factors, the classification and definition of dry eye disease, the major causes of dry eye disease, and the meibomian gland dysfunction and its role in dry eye disease, the core mechanisms or the vicious circle of dry eye disease, and we will end up with a summary. Different terminologies exist to describe dry eye disease. The etiology and management of dry eye disease challenges clinicians and researchers alike. But in addition, we have different terminologies that have been used to describe it, including keratoconjunctivitis sicca, dysfunctional tear syndrome, dry eye syndrome, and lacrimal keratoconjunctivitis. So all these terminologies, they mean dry eye disease, but in our program, we will simply use dry eye disease to describe the clinical case of patients. The complexity of dry eye disease lies in the variability, the lack of correlation between signs and symptoms, the poor repeatability of available tests, and the lack of consensus on which diagnostic tests are to be used. We have also practical challenges that are the typical ones of lack of time and resources, but also the difficulty of obtaining financial compensation for diagnostic tests. So the challenges are significant in the diagnosis and management of dry eye disease. Patients with dry eye disease are also complex patients because patients are frequently well informed about their disease and they have high expectations of treatment, which they wish to be effective, and not only effective, but also long lasting. They can be very varied in the way in which they present to the doctor. Dry eye disease is globally a prevalent disorder. So, despite being under-recognized in many aspects, the prevalence of dry eye disease is high worldwide. And in the same country, the prevalence can vary between several studies. So, look, for instance, in the USA, according to the Women's Health study that took or followed 36,995 patients, the prevalence showed to be 7.8% among women. In the general population, according to the Salisbury Eye study that enrolled 2,420 patients, the prevalence showed to be around 14.6% of the population. In Australia, in people who are aged more than 50 years, the prevalence can reach 16.6%. And in younger people, or in a population that includes younger people starting from 40 years and above, the prevalence showed to be 5.5%. The Asian also, they have several studies, and there is a variability of prevalence between the studies, ranging from 27.5% when we include the young population, up to 33.7% in the elderly population above or equal to 65 years of age. So it is highly prevalent. This is as a conclusion. The reason for the observed variation, as you noticed, in prevalence of dry eye disease across Europe is unclear, but it may be largely due to the lack of a uniform criteria for dry eye disease diagnosis across different prevalent studies. For example, in Denmark, the data for Denmark depends on the assessment criteria used. So when doctors were using the Copenhagen assessment criteria, the prevalence among their patients showed to be 11%. When the doctors were relying on the European Union criteria, the prevalence dropped to 8%. Anyway, reported dry eye disease prevalence with and without symptoms range from 5 to 50% globally, and we explained the reason behind this fluctuation. Up to 34% of menopausal women suffer from dry eye disease, and up to 54% of patients worldwide have dry eye disease that is associated with diabetes. Up to 68% of patients over 40 years of age worldwide have meibomian gland disorder, which is a major contributor in dry eye disease. And reported dry eye disease prevalence based on signs only is up to 75% in some populations. So if we rely on the signs that are reflective of dryness of the eyes without checking other aspects of the eye, we can reach up 75% of prevalence in some populations. What are the economic impacts of dry eye disease? So dry eye disease is not just a simple complaint where people will just complain from dryness or itching in the eyes without other more serious implications. We have some economic impacts. We have cost drivers that are associated with dry eye disease. They can be direct, they can be indirect, they can be intangible. So medically, we have doctor visits, medications, eyewear, humidifiers that are required for patients suffering from dry eye disease, and some surgical costs in very severe cases requiring surgery. So these are medical direct cost implications. And we have the direct non-medical cost implications that are related to management of dry eye disease, such as patient transportation every time he needs to go to the pharmacy to get his medication, or every time he needs to see his doctor to get his eyes evaluated. Indirect cost implications are, for example, lost work time. Patients can sometimes suffer so much to an extent that they can no longer use their laptops or computers. We have lost productivity. Definitely, someone who's not capable of performing his task will be losing his productivity. And some patients also, if they feel very much annoyed by certain particular jobs, will need to switch to another job. There are also some intangible cost implications that are not directly felt, such as a reduced quality of life, or lost leisure time, or impaired social and emotional and physical functioning. Dry eye disease has multiple risk factors. There are many risk factors for dry eye disease, and this slide shows the best established ones. When we say established risk factors, it means these factors were supported by scientific and clinical data, and they showed a very tight connection with dry eye disease. We name, for example, female sex. So female are more at risk of developing dry eye disease. Older age, postmenopausal estrogen therapy, high ratio of dietary omega-3, 6 fatty acids, certain classes of systemic and ocular medications, specifically those containing antihistamines, vitamin A deficiency, hepatitis C, bone marrow transplantation, radiation therapy, refractive surgery are all established risk factors leading to dry eye disease. We can also cite other risk factors that are called suggestive, for which the evidence is inconclusive, and these include diabetes, human immunodeficiency virus, human T-cell lymphotropic virus 1 infection, connective tissue diseases, systemic cancer, chemotherapy, and other medications such as isotretinoin that is widely used to treat acne, antidepressants, anxiolytics, beta blockers, and diuretics. So here we suspect a connection or a correlation between these factors as being potential risk factors for dry eye disease. So after we discussed the risk factors, let's move to the definition of dry eye disease. How do we define dry eye disease? According to the International Dry Eye Workshop, dry eye is a multifactorial disease, so it has several underlying causes. It is a multifactorial disease of the tears and ocular surface that results in symptoms of discomfort, visual disturbance, and tear film instability with potential damage to the ocular surface. So when we talk dry eye disease, we're not only talking about the tears being insufficient, but we are also talking about damage to the ocular surface. Dry eye is accompanied by increased osmolarity of the tear film. This is what we call hyperosmolarity, and inflammation of the ocular surface. And you will understand later on the concept of hyperosmolarity and its impact on the ocular surface. So the ocular surface consists of the cornea, the conjunctiva, and what we call meibomian glands that are located beneath the eyelashes. And they surround the conjunctiva of the eye, and they are responsible of the secretion of the lipid component of the tear film. And all these components, whether the cornea, the conjunctiva, and the meibomian glands, they contribute to a healthy tear film. The tear film is now recognized as a two-layer structure. We have the mucous aqueous layer on one side. Sometimes, and according to some references, we talk about three layers: the mucous layer, the aqueous layer, and we have the lipid layer that is external, that is in direct contact with the external environment. Goblet cells contribute mucus formation, and the mucus layer covering the epithelial cells is formed by something we call glycocalyx, which is formed by transmembrane glycoproteins and mainly produced by the epithelial cells. So both the epithelial cells and the epithelial cells of the ocular surface and the goblet cells are contributors in the production of the mucus component of the tear film. Excuse me. We also talk about something named lacrimal functional unit. Dry eye disease can be understood as a disturbance of the lacrimal functional unit that comprises the ocular surface, the lacrimal system, and the connecting nerves. So there are three components of the lacrimal functional unit. The DEWS, so the Dry Eye Workshop, definition of the lacrimal functional unit is as follows. It is the integrated functional unit comprising, from one side, the lacrimal system, on the second hand, the ocular surface and its accessory glands and their neuronal interconnections that is responsible for the maintenance of the tear film and the protection of the transparency of the cornea and the health of the ocular surface. So remember the three components of the lacrimal functional unit. The ocular surface, the interconnecting innervation, and the lacrimal system. And when we talk about interconnecting innervation, we have two parts of nervous control, one that is responsible of tear secretion and one that is responsible of tear clearance. And a normal lacrimal functional unit is where there is a balance between both nervous pathways, the one leading to tear clearance and the one leading to tear secretion. So in summary, dry eye disease is a disturbance of the lacrimal functional unit. In this slide, you see a healthy, stable tear film with the lipid component or the lipid layer, the mucin layer, and the aqueous components, and normal hydrated epithelial cells of the cornea and the conjunctiva, so of the ocular surface. This is a normal, healthy tear film. Now let's move to the next slide to see a tear film that suffers, or an eye that suffers from dry eye disease. Before that, we know that water evaporation from tears is normally 33% of the total tear flow. So in a normal eye, we have 33% of the total tear flow that gets evaporated. In dry eye disease, we have a damaged tear film and a damaged ocular surface with dehydrated cells and increased evaporation rate of the tear film. So when we have a compromised tear film, we have a defective lipid layer. You see here the lipid layer of the tear film. It is not consistent. We have dehydrated epithelial cells, and we have a disruption of the osmotic balance between the tear film itself and between the epithelial cells of the cornea. And we talk here about an increase of the water evaporation rate, so the water that is contained in the tear film. In the case of dry eye disease, we have an evaporation of 75% of the total tear flow versus 33% in a normal eye not suffering from dry eye disease. We spoke about the definition, the risk factors. Now let's talk about the different types of dry eye disease. We have different classifications according to different references, but the most commonly used classification of dry eye disease is the last one that is based on the dry eye workshop that took place in 2007. We had, according to that workshop, tear deficient dry eye, evaporative dry eye, and we have 4 levels of severity of dry eye disease. And we have also classification based on etiology, so on the underlying cause behind the dryness of the eye. And you will see later what is causing the tear deficient dry eye type and what is causing the evaporative dry eye type. So dry eye disease is classified into tear deficient or aqueous deficient and into lipid deficient or evaporative dry eye disease. Aqueous tear deficient dry eye results from reduced lacrimal tear secretion and volume. So when we talk about aqueous deficiency, there should be a problem in the rate of secretion, the quality of the tear that is produced by the lacrimal glands, and also the volume of the tears that are produced by the lacrimal gland. On the other hand, when we talk about evaporative dry eye disease, this results from another cause. It results from excessive water loss from the ocular surface in the presence of normal lacrimal secretory function. So we have a production that is adequate in terms of volume and of quality, but the water component of the tear film that is normally produced is excessively evaporated due to a disruption in the consistency of the lipid layer of the tear film, which makes the evaporation higher and jumping from 33% in a normal eye to 75% in a lipid deficient dry eye disease or evaporative dry eye disease. So keep this in mind. We have 2 types, aqueous deficient dry eye disease and lipid or evaporative dry eye disease, lipid deficient or evaporative dry eye disease. The cause of aqueous deficient is a lack of production in terms of quantity and of quality and volume. And we have on the other side the evaporative dry eye disease, where we have a lack of production of the lipid layer and leading to an increased evaporation rate of the watery component of the tear film. Again, the aqueous deficient and the lipid deficient dry eye disease. So lipid deficiency is another nomination of evaporative dry eye disease. And the major distinction between patients with aqueous deficiency is that they are Sjogren or non-Sjogren's patients, and we say Sjogren syndrome is a syndrome that is autoimmune and that leads to desiccation of the salivary gland and of the lacrimal glands. Some other patients, they have aqueous deficiency despite being non-suffering from Sjogren syndrome. So there are two subtypes. For the evaporative type of dry eye disease, the majority of the cases are caused by a syndrome that is called meibomian gland dysfunction. And the meibomian glands, as I told you before, they surround the eye membrane under the eyelashes. So they are located there, and they are responsible of the secretion of the lipid component of the tear film. And if we have a problem at the level of the meibomian gland, then we have a lack of production of lipid layers, leading to an evaporation of the watery component of the tear film. Meibomian gland disorder is the most common cause of evaporative dry eye, and it is associated with a deficient tear film lipid layer. Evaporative dry eye has been termed lipid deficient dry eye disease. So you can consider them one kind of disease. Several studies show that lipid deficient dry eye disease is common. Here we have a cross-sectional study that was performed in 200 patients in a dry eye clinic in Singapore. Evaporative dry eye was behind 58% of the cases, so it was the most common type, followed by what we call the mixed evaporative, where we have an aqueous deficiency component and a lipid deficiency component together, followed by the aqueous tear deficiency that was responsible of 30.5% of the types. A further observational cohort study was performed across 10 sites in the European Union and the United States. And here we had 224 subjects identified as having dry eye disease, and they were classified as purely evaporative dry eye disease with a number of 79 out of 224 subjects, or purely aqueous deficient, 23 out of 224 subjects. Both evaporative and aqueous deficient were 57. So the major cause of dry eye disease, according to these two studies, was the evaporative type that is due to meibomian gland disorder in most of the cases. As a conclusion, evaporative dry eye is more common than pure aqueous deficiency, but in many cases, both together occur together. So we have, in many cases, at the same time, a dry eye disease that is caused by both aqueous deficiency, so an inadequate production of the aqueous component by the lacrimal glands, and at the same time, an inadequate production of the lipid layer by the meibomian glands. Here, the figure on this slide is adapted from the comprehensive sequence of events presented within the paper. So it illustrates the underlying factors and the core mechanisms that are involved in the pathogenesis of meibomian gland disorder. We have other associated factors that are not shown on this slide and that are involved, such as altered cell differentiation, seborrheic dermatitis, bacterial growth, inflammation and aging process, and contact lens wear, that are also contributors or underlying causes of meibomian gland disorder. But those that are well confirmed are age, hormonal disturbances, sex, environmental factors are leading factors or leading causes behind meibomian gland disorder. We have also hyperkeratinization and increased viscosity of the meibum or of the lipids that lead to the obstruction of meibomian gland with low delivery and secretion of meibum and deficiency of tear film lipid layer as a final result. So, age, hormonal disturbances, sex, and environmental factors, they can cause a hyperkeratinization in the tissues of the eye or an increased viscosity of the secretions of the meibomian gland. This will lead to an obstruction of the canals that let the meibomian gland, let's say, secrete the meibum to the eye. So we have low delivery and secretion of meibum, and this will be behind the low quantity of lipids that are delivered to the tear film. The diagnosis of meibomian gland disorder is based on features such as the presence of orifice plugging and thickening, or absence of expressed meibum. There are some specific clinical diagnostic tests that we'll see in the later modules that help the doctor identify a patient suffering from meibomian gland disorder. Meibomian gland disorder can be associated with dermatosis such as acne, rosacea, seborrheic atopic dermatitis. And diagnosis is based on morphological features of the gland, including acini and duct orifices, presence of orifice plugging, thickening, or absence of expressed meibum. Now let's talk about the key mechanisms of dry eye disease and the vicious circle of dry eye disease. The four key mechanisms of dry eye disease are tear film instability, followed by tear hyperosmolarity, followed by apoptosis of the epithelial cells of the cornea, followed by inflammation, and the inflammation also will affect the goblet cells that will become dead at their turn. And by reducing the quantity of goblet cells due to inflammation, we will have further instability of the tear film, because goblet cells, remember, are the cells that produce the mucus part of the tear film. So the four target areas contributing to the pathophysiology of dry eye disease are tear film instability, tear hyperosmolarity, apoptosis, and inflammation. These core mechanisms are primarily driven by tear hyperosmolarity and tear film instability. So in most of the cases, the first incident is either tear film instability or tear hyperosmolarity. And it is possible to enter the vicious circle at any point, but most frequently we have the tear film instability and the hyperosmolarity that occurs first. And look here at the meibomian gland disorder. That is also one of the causes of tear film instability, because we have changes in the lipid constitution of the tear film. Several factors can be contributing in the occurrence or in the initiation of this vicious circle. We have lid margin irregularities, some topical drugs containing preservatives. For example, some preservatives that are contained in eye drops can cause tear film instability. We have also allergy. We have contact lens wear, environmental factors, bacterial conjunctivitis, LASIK refractive surgery, ocular surgery, Sjogren syndrome, systemic drugs like antihistamines, and some autoimmune diseases and cases of sex steroid hormone imbalance. These are external factors to the eye that contribute also in the initiation of the vicious circle, basically starting by tear film instability, leading to tear hyperosmolarity, to cell damage and apoptosis of the epithelial cells of the cornea, and to nerve stimulation and inflammation with the release of cytokine release matrix metalloproteinase that is responsible for the destruction of goblet cells, leading to loss of mucus component of the tear film and further tear film instability. So to understand these four key areas is important because based on our understanding of these four areas, we can prescribe effective treatments, and we can perform accurate diagnosis. This slide will explain the hyperosmolarity. So it illustrates how as water evaporates from the tear film, the concentration of compatible solutes increases in the tear film, leading to a hyperosmolar tear film. So this in turn draws water out of the cells of the conjunctival epithelium, resulting in their apoptosis and death. So let me further elaborate. You have this aqueous layer here that is sandwiched between the lipid layer and the mucin layer of the tear film. The lipid layer is the layer that is in direct contact with the external environment, while the mucin layer is the layer that is in direct contact with the epithelial cells of the conjunctiva. When we have evaporation that is increased due to an inconsistent lipid layer, mostly in the cases of meibomian gland disorder, then the aqueous part here will evaporate at a higher rate. So we will be lacking enough water, and as a result, that part of the aqueous layer will become highly concentrated in solutes. And if you remember chemistry, when we are with two zones that are separated by a semi-permeable membrane, whenever one part or one side becomes hyper-concentrated, it means hyperosmotic, the nature of things will lead the neighboring side to lose some of its water to reestablish the balance from both sides of the membrane. So here in this case, we have an evaporation of the water that is contained in the aqueous layer because the lipid layer is not homogeneous. As a result, you see that we have a hyperconcentrated aqueous layer that lacks water, but now it is highly concentrated in solutes. And as a result, the neighboring epithelial cells of the conjunctiva will give out their water in order to reestablish the balance or the chemical balance between themselves and between the aqueous layer of the tear film. So when these epithelial cells, they give their water in order to reestablish the chemical balance, they are shrinking in size. They were, look here, this is, a schematic representation. but they were bigger in size, more hydrated. Now they have lost their internal water. They become small in size and they are dehydrated. And when they become dehydrated, they are at higher risk of apoptosis. When we say apoptosis is cell death. And here is what happens in case of a hyperosmotic tear film. But remember, tear film instability is the beginning of everything. And in this case, the instability is due to a lack of lipid component of the tear film. So tear film instability is frequently the initiating event of dry eye disease vicious circle, unrelated to prior tear hyperosmolarity. However, the most common causes of evaporative dry eye is a deficient tear film lipid layer due to meibomian gland disorder, and a normal tear film lipid layer reduces water evaporation by about 90 to 95%. So, based on that, now we know that dry eye disease can be existing despite the fact that we have a normal quantity of tears that are produced. Why? Because the problem is not in the production of tears and in the quantity that is produced. The problem is in the evaporation rate of the tears. Tear hyperosmolarity is considered the main cause of damage to the ocular surface, and we've explained why. In aqueous deficient dry eye disease, it results from normal evaporation rate, but with reduced water secretion rate. And in lipid deficient dry eye disease, which is more frequent, we have tear hyperosmolarity as a result from an increased evaporation rate despite a normal water secretion rate by the lacrimal glands. The tear hyperosmolarity activates a cascade of pro-inflammatory products, and as a result, we will have loss of goblet cells that are responsible of mucin production. So when we lose goblet cells, we have an altered mucin production and further apoptosis of the epithelial cells, because remember, the mucin or the mucus layer is the one that is in direct contact with the epithelial cells of the cornea, and this is in brown. So you can classify your patients as lipid deficient or aqueous deficient, and you can also classify them as mixed when they present with both two underlying causes of dry eye disease. And depending on the underlying cause, this will have consequences on the way the doctor or the pharmacist will try to manage dryness of the eye, because there are some eye drops that deal with the aqueous deficiency and some other eye drops that focus more on the lipid deficiency. So if you are not tackling the principal issue by giving the appropriate eye drop, you will be giving a drug that will not have any efficacy. So it is very important to know what kind of dry eye disease the patient is suffering from. What is the mechanism through which the cell responds to hyperosmolarity? So in response to a hypertonic environment is an environment that is poor in water and rich in solutes. Cells will take up inorganic ions, leading to cell damage and death. Why? Because cells try always to restore their cell volume with whatever is available in their surrounding environment. So a normal cell, once it loses water, it becomes dehydrated, and it has a mechanism of restoring its volume, because this is the nature of things. So the first thing the cell will try to restore its volume with are the surrounding inorganic solutes. And this will disturb the internal balance of the cell, leading to a decreased cell function, to stress activation, to cell damage, and to death of the cell. So in dry eye disease, the quantity of water in tear film is decreased due to either increased evaporation or insufficient water production. And this what happens to the epithelial cells that give out their water to the aqueous layer in order to reestablish the chemical balance. And as a result, they become desiccated, dehydrated, and they try to restore their volume by taking inorganic solutes, incompatible solutes, that will disturb their health and that will put them under stress and lead to their death and apoptosis. So we mentioned now the tear film instability. We spoke about tear hyperosmolarity. Let's talk about the third mechanism, which is apoptosis. Apoptosis is another key feature of the vicious circle of dry eye disease, and cell death by apoptosis causes epithelial damage to the ocular surface. It causes loss of goblet cells that are the producers of mucin and disturbance of mucin expression. The epithelial injury now stimulates the corneal nerve endings. So now, due to apoptosis, we have a stimulation of the nerve endings that are located in the cornea of the eye. And this gives rise to more discomfort, increased blinking, and compensatory reflex lacrimal tear secretion. There is also evidence that damage to the corneal epithelia can affect the visual function of dry eye patients in severe cases. The fourth core mechanism is the inflammation. The inflammation has two major consequences in dry eye disease. It can lead to tissue destruction and to neurosecretory block mediated by inflammatory cytokines such as the matrix metalloproteinase. So it is thought that chronic neural damage eventually leads to reduced reflex tear secretion. It leads to loss of sensory drive to the lacrimal gland and decreased corneal sensitivity. Altogether, they will alter the tear levels of the neuromodulators that are called CGRP, NPY, and LGF in dry eye disease that correlate with clinical severity. So when we say CGRP, these are neuromediators, the calcitonin gene-related peptide, the neuropeptide Y, and the nerve growth factors that become altered in dry eye disease. And the more they are altered, the more this correlates with the severity of dryness of the eye. So at the end, dry eye disease is common, but it is often under-recognized. It is multifactorial in origin, and it can be broadly categorized as arising from either aqueous or lipid deficiency. Dry eye disease is a vicious circle of interacting factors, and the core mechanisms of this vicious circle are tear film instability, most of the time the initiating problem, followed by tear hyperosmolarity, by epithelial cell apoptosis, and by ocular surface inflammation. So that was all for today. I'm happy we finished on time, and the floor is open to questions. Questions? So, would you recommend that a patient with xerostomia and Sjogren syndrome be screened for dry eye disease? Definitely, because Sjogren syndrome is one of the leading causes of aqueous deficient dry eye disease. So, these patients, most of the time, they develop dryness of the eye that requires treatment. And we know that untreated dry eye disease can, in some cases, lead to vision loss because of this cascade of inflammation and of affection of the nerve endings in the corneal surface. More questions? Well, preventative measures, they start by modification of our way of life, like reducing our hours of using the computer, of getting exposed to air condition or getting exposed to dry weather. So this is what can a patient start by reducing the environmental contributors to dry eye disease. And definitely, continuous monitoring is a key thing that doctors should do for their patients in case they suffer from Sjogren syndrome and they did not yet develop dry eye disease. So once they start detecting dryness of the eyes, the doctor will immediately put the patient on artificial tears to block this vicious circle of events. Well, they can help because they keep the eyes humid. There are the warm compressors, but there are also some specific eyeglasses that look a lot like the swimming glasses. And the principle is the same, is to keep the humidity of the eyes as much as possible and as high as possible. We will see in the next modules what are the effective treatments, starting from medications to modifications in the way of living to other also devices and surgeries. So you will be requested to take a post presentation test just for your evaluation of knowledge. I hope this presentation was clear for you, simple, and that you will leave with a better knowledge of dry eye disease. And hopefully, we will get another opportunity to follow up with the other modules that cover diagnosis, treatment, implications on quality of life. So the drops, Allergan, in Allergan portfolio, there are many eye drops. We have the Optive range of products. We have Optive Fusion and Ultra, and each category of Optive is addressed to a different kind of dry eye disease. And David can also explain to you more what to prescribe in the case of aqueous deficient dry eye disease, lipid deficient dry eye disease, and in patients who suffer from dryness, excessive dryness during night time. I know in Ghana we have the Refresh range of products, and Optive is also about to be registered very soon. And what composition? So these are artificial tears. Some they contain lubricants, eye lubricants that maintain the ocular surface hydrated. Some others, in addition to the lubricants, they contain substances called osmoprotectants. And these substances that are the osmoprotectants, they help the dehydrated epithelial cells restore their original volume without making appeal to the surrounding inorganic solutes that can be harmful to the cell functioning and that lead to apoptosis. And you have drops, you have single-use drops, and you have also gels that are very much adequate for night use because they have a double concentration of the lubricant carboxymethyl cellulose. Any more questions?
Hello, Ruba.
Yes, Dave.
Thank you very much for a concise and then the well-delivered presentation. I was
Thank you.
having a network challenge here. That's why I couldn't respond immediately. But thank you
Mhm.
so much. And I also want to thank the participants for taking their time to join us. We know that with this information, you'll be able to manage the dry eye disease more concisely and effectively at the pharmacy shops. We want to assure you that we'll come to you for follow-ups, and then if you have further clarification that you needed from us, then we'll be there to also deliver to you. We thank you very much, and we assure you that we will be doing this quarterly as we have now partner CES. Thank you very much, and thank you, CES.
Thank you, CS, for the perfect organization of our first presentation, and we'll be looking forward to more presentations. Thank you for the audience and for making time to our presentation and for your attention and patience. Have a great evening and see you soon.
Thank you. Over to you.